just going to introduce myself. I know many of you well, and some in passing. So I just want to thank you all for joining us tonight. My name is Chris Pearce, and recently been appointed at the Epilepsy Foundation to specifically work in the rare and genetic space, so complex epilepsies and what we can do better in that space, find out what the gaps are and what the services are that we can do to improve outcomes for our loved ones. One of the issues or challenges that our families face is getting the correct support, and NDIS is a really big part of many of our support systems. So we've reached out to NDIA to have a chat to us. And with that, I'd like to introduce Aaron Byrne, who is the Assistant Director of Community Engagement and Communications in West Central at the National Disability Insurance Agency. Before I hand over to Aaron, I just want to go through a little bit of housekeeping. So please feel free to put your videos on, show your face. It's really up to you. We're going to keep microphones off. We will have a question and answer section at the end, so there's opportunity to ask questions then. But also, as we're going through, you think of a question you'd like answered, please pop it in the chat, so then we know that we can either get to it in this session, or I can work with Aaron to get an answer back to the group. It's important, this is important, particularly for us getting approval to share it beyond this meeting, is that when we're asking questions, we're not using anyone's names or anything that can identify someone that may be a participant. So just please use general questions, like what would happen in this scenario, and no names. And then I just wanted to preface the presentation. Aaron and I met and had a really good conversation around what our community needs, what our challenges are, what the mix between medical and disability and how that can sometimes be challenging. So Aaron's presenting what he's able to within the NDIA system. So some of it might seem not as relevant, but what we're doing is trying to contextualise the life trajectory of someone with a complex epilepsy and what sort of things that might change over that life trajectory. So some will be rated to children, young adults, or maybe even older. So just keep a broad mind about what we're talking about, and we will get to any questions at the end. And with that, I will hand over to Aaron, and you can go from there, Aaron.
Thanks, Chris. I think that was a really good overview. I think the other thing to add is maybe some of the questions that are asked will help us in the future to create presentations as well. Yeah, and the other thing is we want to be open with the information, but sometimes some of the things that we're presented with, maybe broadly from the agency, there aren't answers about that yet, or it's something that we need to continue to work with the various systems to get some clarity on where that best sits. So thanks for that. So basically, as Chris said, just going to have an overview of the NDIS with some health-related supports specifically around epilepsy and complex epilepsy. So yeah, if you're ready, Chris, that would be great. Put up the presentation. And sorry that I cannot host the presentation. NDIS, a lot of complexities with these type of things. Normally we present on Microsoft Teams, but Zoom is the preferred platform for a lot of people. So if you can bear with us, that would be great. And as Chris mentioned, we will be able to send these slides out to everybody afterwards. So before we start, I'd like to acknowledge the traditional owners and custodians of the country on which we all meet today. So for me in South Australia, I'm meeting on the land of the Kaurna people in Adelaide. We pay our respects continuing connection to land, sea and community. Also pay my respects to elders past, present, emerging. And I would also like to extend that acknowledgement and respect to any Aboriginal and Torres Strait Islander people here with us today. So next slide, thanks, Chris. So basically, as I said, we're going to have a presentation that looks at what is the NDIS. Obviously, a lot of you will understand that, but sometimes it's important to have that background to really understand what sits under the NDIS and what sits under other systems. Eligibility, responsibilities of the health system, state and territory government responsibilities, disability requirements, funded epilepsy supports, some case studies to kind of really put into practice some of the things that we mentioned. And also there will be a link to some additional resources. As I said, you'll have copies of this presentation. So what is the NDIS? So you would all really know what the NDIS is, I hope. So the NDIS obviously is the National Disability Insurance Scheme. It provides all Australians under the age of 65 who have a permanent and significant disability with the reasonable and necessary supports they need to enjoy an ordinary life. Now, obviously, when we come up around the NDIS, reasonable and necessary supports is something that comes up a lot. So we call supports that meet the NDIS funded criteria reasonable and necessary supports. So the NDIA applies the NDIS Acts and rules when determining the reasonable and necessary supports a participant will receive. So reasonable means something that is fair, and necessary means something a person needs. So the NDIS funds supports and services that relate to a person's disability to help them achieve and meet their needs. A support or service must be related to a participant's disability, must not include day-to-day living costs not related to a disability. Support needs such as groceries is an example of something that really would sit outside the NDIS. It should represent value for money, must be likely to be effective and work for the participant, and should take into account support given to a participant by other government services, which is really important to understand, because sometimes when we talk about what sits with health and what sits with other systems, that's why at times that the NDIS may not fund something, as that sits better under another service. Now, that's not taking into account where there may be gaps in those other areas. So, for example, we do hear regularly that there are gaps in what health understands is under their responsibility. The same with education. So we take into account all supports given to a participant by other government services, their family, carers and networks and communities when we're making any decision around what we fund. So the NDIS is a lifetime approach, which means that it's designed to help people to get the supports they need so that their skills and independence improve over time. Saying that, there are some people that are going to need more support than other people over their life. And the idea is that the NDIS should flex up and flex down, because as we know with life, we don't plateau. There are peaks and troughs, and at different times we may need different supports. And this is the same for participants on the scheme. Initially, when we set up the scheme, we thought that there were going to be 500,000 people accessing the scheme. This was from existing people that were accessing disability services. This has really increased a lot. And a lot of that's got to do with people who weren't accessing services before. They're more aware of what is available and how to access the NDIS. NDIS is really based around helping people achieve their goals, and this is what the basis of how a plan will be funded. It's also important to note that the NDIS isn't just around funding participants' plan, it's around building the capacity of the community to be able to support people with a disability to lead the lives that they want to lead. And this sometimes can be through ILC grants, through us doing sessions like this tonight, but then also focusing on particular groups or supports that may need some education around that expectation, around what they provide under the change that the NDIS has brought. So, next slide, thanks, Chris. So that was a big slide, sorry, it was hard to judge because there's a lot of information there. So it's important to know who's delivering the NDIS. So if you are dealing with the NDIS, you should have a bit of an understanding around this. So the NDIA is the independent government organisation that runs the NDIS. So I work for the NDIA. The NDIA is the National Disability Insurance Agency, and we are facilitating the National Disability Insurance Scheme. We have partners that help us do this work, and they're known as partners in the community. Within South Australia, there are a number of different organisations that are doing this, but it changes from state to state. And the best way to find out who the partners are within the relevant area that you are is to go to the NDIS website, and there is normally a map that shows who the partner is for each region. So we have EC partners, which are early childhood partners, and these are teams of allied health professionals and early childhood educators who are contracted to deliver the early childhood approach, which goes from 0 to 7, for participants when they are first getting on the scheme. Important to note that sometimes that people won't get full access to the scheme through the ECI. What this means is the ECI approach is meant to look at a developmental delay and giving some intensive support to potentially lessen the need for NDIS later on in life. But this doesn't mean that somebody that comes in on an ECI approach won't be able to get access to the NDIS later on. When they come to the end of that early childhood approach, they can re-look at their access, or for some people, they get full access to the NDIS when they first join up as an ECI through the ECI pathway. Really important to understand that distinction, because sometimes when people get access on the 0 to 7 age group, they think they've got full access to the scheme. Just important to remember that and question when somebody is coming through an ECI, that have they got full access or are they just under the ECI pathway? Something just important to note. The early childhood approach is based on the principles of best practice in ECI to achieve better long-term outcomes for children through timely, targeted and individualised early childhood intervention supports. So also involved in this is an LAC. So for those aged above 7 and above, they would be dealing potentially with an LAC or a local area coordinator who is linked in with a partner in the community. So local area coordinators employ local area coordinators, commonly referred to LACs, who help people understand and access the NDIS. For most people aged 7 years and older, an LAC will be the main point of contact. So a lot of people, that is their only interaction with the NDIS. An LAC will help people with disability to connect to supports, services and local activities. They also help participants to understand the NDIS, meet with participants to create their plan and explain how to make the most of it. 80% of all participants will engage with partners directly rather than the NDIA. However, in areas where there are no partners in the community, for example, remote or very remote areas of NDIA of Australia, sorry, not the NDIS, the NDIS plans will take on this responsibility. So both EC and LAC partners conduct the planning meetings, including the plan review. So if someone is not eligible to join the NDIS, partners still provide support and connections to local supports and services. So really important to note that too, that's what the partners in the community are also funded for. Those people that don't get access to the NDIS but are wanting to know what is available in their area in terms of disability supports. Okay, next slide. Thanks, Chris. So just a brief overview of eligibility. So to join the NDIS, a person must have a permanent disability or a developmental delay if they're aged between 7 and 65 years of age that significantly affects their ability to take part in everyday activities. A lot of the time when we are talking about the access to the NDIS, it's really around how that disability affects the participants' functionality or their ability to engage with the community. So this is an important thing to note, that that's what we're really trying to understand, is how that disability is affecting that participant's ability to live the life that they want to lead. And this is important to note too, because sometimes when we talk about disability, there is a difference between what people are funded at, because the disability is only part of the getting onto the scheme. The planning side of things is that next step to really understand what the individual supports are for each person. When somebody is accessing the NDIS, they must be aged less than 65 years of age when they apply. So what that means is if someone is 64 and 364 days of age, they make an access to the NDIS, this will be considered. Saw the question, we can come back to it later because I wasn't able to read it, sorry. Also must be an Australian citizen or protected special category visa. If this criteria is met, access request to join the NDIS needs to be made. If someone is not eligible, the NDIS employs partners in the community who can still support and provide those connections, as we said before. So it's really important to understand that when you are accessing the NDIS, it's really about understanding that disability and how it affects the participant's ability to lead their lives. Now, quite often that there is that distinction between what sits with health and what sits with the disability service to cover. So that's just an important note there. So further to that, in addition to meeting age and residency requirements, an access request will need to meet the disability requirements. So a person must have a permanent and significant disability or impairment that affects their everyday life and is likely to require support under the NDIS for life. A person must satisfy this requirement regardless of whether the impairment came about through birth, disease, injury, or accident. To be eligible for NDIS funding, the disease or medical condition must cause a permanent impairment resulting in a significant disability. This impairment must relate to either physical, intellectual, cognitive, neurological, visual, hearing, psychosocial, or a combination of all of these, or more than one. The NDIS will not provide funding or supports for time-limited conditions, so non-ongoing conditions, or chronic health conditions unrelated to a person's disability. So, for example, reduced mobility due to an acute injury, such as a lower limb fracture, will not meet the NDIS disability requirement, as this condition is likely to resolve. The NDIS will not provide funding or supports for chronic health conditions that are not related to a person's disability. It is important to differentiate between treatment and care of chronic health conditions and associated comorbidities for disabilities. So two disabilities existing within the participant. So, for example, a physical and multiple disability, also maybe an intellectual disability as well. For example, the NDIS will fund disability supports for a person who has a lower limb amputation due to an artery disease as a result of diabetes. This is because there is a physical impairment resulting in disability secondary to a health condition. However, the NDIS will not fund dietetic supports for issues related to food allergies, cardiovascular disease, renal disease, polycystic ovarian syndrome, or irritable bowel syndrome. A disease are not a direct result of a participant's disability. Next slide. Thanks, Chris. Oh, I actually was talking to the other slide. So that is the slide there. So next one, thank you. That was the right one. So streamlined disability requirements. So under the operational guidelines, some disabilities and conditions will mean the access process is streamlined. So for example, disabilities under List A do not require further evidence as they will automatically meet disability requirements. So autism diagnosed by a psychologist, pediatrician using a DSM-V as having level 2 or level 3. So the DSM is an assessment tool. Cerebral palsy diagnosed as level 4 or 5 using a gross motor functioning classification system. A spinal cord or brain injury which resulted in severe or total loss of strength and movement of the body. A permanent blindness in both eyes, or amputation or congenital absence of 2 limbs. So if we see a List B, so conditions under List B meet the requirements of having a permanent impairment, but evidence will be needed to provide about the impact of the person's impairment on their day-to-day life. The list of these conditions is extensive and includes Asperger's syndrome, Alzheimer's disease and dementia, Down syndrome, Parkinson's disease, amputation, Huntington's disease, multiple sclerosis, spina bifida. The full list is available on the NDIS website. But as mentioned in the previous slide, epilepsy conditions alone will not satisfy the access criteria. Normally, those with epilepsy support will have other conditions and impairments which may meet that access criteria. If someone is not eligible for the NDIS, then they can still receive support with connection to other supports and services. So if a person meets initial criteria, an access request needs to be made. The easiest way this can be done is either to call the 1-800 800 110 number to complete an access request form verbally across the phone, or download the access request form from the NDIS website. For children under age 7, their parents can contact the NDIA directly or their local early childhood partner. A request can be made by either the individual or a representative, including a guardian, someone with a power of attorney, or in the case of children, their parents. Also important to remember that the partner in the community is also somebody that can help give guidance around the access process. So it's also important too to note that there's a participant service guarantee that the NDIS has created and put on the website. And it talks about a number of timeframes for when we are finalised or to achieve outcomes around various aspects of the scheme. So under the participant service guarantee, the service standard one can expect for access is make an access decision or request for more information after an access request has been received. So this should take no more than 21 days. Allow sufficient time for prospective participants to provide information after the NDIS has requested further information, 90 days or 3 months. Make an access decision after the final information has been provided, 14 days. So it's important to note that this service guarantee is the principles by which we as an agency are aiming to meet the responses to the various areas in relation to planning and access. On February the 15th of 2021, it's important to note that the access request form was updated to make it easier. So the form can be filled out on the applicant's computer so they can fill out their parts and email it to treating health professionals to fill out other parts. The form uses plain English to make it easier to read, provides information around the questions we are asking, and a separate section added for the applicant's doctor or treating health professional with clear instructions. So this is something that we've directly adjusted due to feedback from stakeholders and participants. So I think it's important to note that if things aren't working, it's important to talk about them and raise them, because the agency, although it's been around for a little while, is still quite new, and we are further developing and looking at ways to improve the way in which we provide supports and create plans for participants and their stakeholders and supports. So just next slide, thanks, Chris. So yeah, just a little bit more information around the access request form. So section 1 is to be completed by the applicant or their representative. This section asks for information about their name, date of birth and address. It will ask for consents to use the applicant's Centrelink reference number to verify their age and proof of address. It will ask for consent to use the applicant's Centrelink reference number to verify their age and proof of address. If the person doesn't provide consent to use their CRN number or Centrelink reference number, they will need to provide us with certified copies of the relevant information before we proceed with their application. The section will also ask the details of the carer and legal guardians, as well as information about disability and whether it's related to accident or events involving compensation. If the individual has received compensation, it does not have an impact on whether they can or access the NDIS. Information around compensation, is so the NDIA can identify what supports have been provided for, as the NDIS does not duplicate supports funded by other systems. Section 2 is to be completed by the treating health professional. This section will ask about their disability and other impairments, what treatment interventions have been provided, information around previous assessments that have been completed, how the applicant's disability has an impact on either their mobility, communication, socialising, learning, self-care or self-management. So next slide, thanks, Chris. So this is just a table that gives a kind of an overview of what system is responsible for what, that being the health and the NDIS. So the health system diagnoses and treats a person's medical condition. The NDIS manages a person's ongoing support needs resulting from their functional impairment, where the support need is ongoing and is best funded by the NDIS. So the health system's responsibilities include assessment, diagnosis, and clinical treatment of health conditions, including ongoing or chronic health conditions and acute, post-acute care. All supports directly related to the person's health status, treatment and health interventions, rehabilitation and support after a recent medical or surgical event, rehabilitation support services, which are time-limited, goal-orientated services and therapies, examples of which include general practitioners, medical specialists, dental care, care in hospitals, palliative care, and pharmaceuticals. The NDIS's responsibilities include supports directly related to a person's functional impairment and required an ongoing, regular basis, supports enabling the person to undertake activities of daily living, provides permanent aids and equipment. Examples are such as personal care, domestic assistance, and community access and assistive technology. Next slide, thanks, Chris. So important to talk about the education system, as that's another system that is funded to provide support to everybody. So the education system is responsible for making reasonable adjustments to the personalised learning and support for students that primarily relate to their educational attainment. So these include teachers, learning assistants, and other supports, such as Auslan interpreters, general support, resources and training for teachers, tutors, and other staff, therapy delivered in schools for education or training purposes, such as allied health practitioners, helping teachers and trainers adjust curriculums, aids and equipment to make curriculum accessible, such as modified computer hardware, software, and Braille textbooks, adjustments to buildings such as ramps, lifts, and hearing loops, transport for education or training activities, such as excursions, field trips, and sporting carnivals, day-to-day supervision of students at school, including behavioural support. The school should make sure students with a disability have the same opportunities as other students to fully participate in the class and other activities. The applied principles for school education recognise that the NDIS will fund reasonable and necessary supports that the student requires due to the impairment on their functional capacity, and additional to reasonable adjustments which are the responsibility of schools, i.e. those adjustments not primarily relating to education attainment. So the NDIS funds specialised transport required because of the student's disability, transportable equipment such as a wheelchair or personal communication devices, therapies a family and school have agreed may be delivered during school time but are not for educational purposes, self-care at school related to a student's disability, like support with eating, specialised training of teachers and other staff about the specific personal support needs of a student with a disability. So examples of situations where we may be able to fund extra supports. So help to fund or keep a part-time job outside of school hours. We might be able to fund support for extra help required because of the student's disability, such as help to build skills to get a job. These might include things like working in a team, staying on task, or learning to catch a bus or train. Work experience as part of the school curriculum. This is the responsibility of the school. However, if a student needs extra supports because of their disability to be able to do work experience, the NDIS may look at help with that. School-based traineeships, where a student combines school study and work. The NDIS can't fund supports that are a responsibility of the employer, school, or traineeship provider. However, if there are extra disability-related supports to the student's needs, the NDIA may be able to fund those to help the student to successfully complete their traineeship. Support coordinators, LAC coordinators, or planners can give participants more information around these supports. So higher education. So some participants may also want to complete further education through universities or TAFE. Higher education providers do help support students with health conditions, including disabilities. Supports can range from advocacy, mentoring, career advice, and exam adjustments, but they can vary depending on the condition and the higher education provider. These services are typically managed by a disability advisor or inclusion unit. If an NDIS participant wants to complete further study, they can receive additional funding if it's reasonable and necessary to their goals and disability needs. We consider funding the extra support a participant needs at university, TAFE, and during apprenticeship or other training because of their disability. These supports should allow a participant to go about their daily activities and may include personal care supports while at a university or TAFE or undertaking approved placements, transport to and from university or TAFE and if unable to drive or use public transport, training for universities, TAFE or employers during placements about the participant support needs, support to take part in specific projects run by university for people with disabilities, and NDIS support for participants. As individuals' needs and goals change, they should share these with the NDIS planner to ensure their plan is tailored to their needs. So the NDIS doesn't fund supports the university or TAFE needs to provide as reasonable adjustments or anything as part of usual teaching. We also don't fund things everyone has to pay for themselves. This means we don't fund changes to the building to make sure a person with a disability can access it, like ramps, changes to learning materials to make sure it suits the person's needs, textbooks or general equipment needed for education or training, course fees. And this is all supported by the NDIS Act's Section 34(1)(f), NDIS supports for participants, Rule 7.16. So it's important to know that this is aligned with information that's available out in the public sphere. So the NDIS has the Act to help support what it will and won't fund, and also helps to explain where those other supports should sit, noting that there may be gaps in those other systems currently, and they still need to develop their skills to actually meet the needs of people with disability. And that's part of the role of my team as well. So we do meet regularly with a number of these supports, especially in health, to help understand where there are gaps, help to understand what the expectation is under the NDIS, but then also when we know those gaps, we can take them back to the NDIS and look at when the various governments meet throughout the year, that they have supportive evidence to go and discuss adjustments that may need to happen. So next slide, thanks, Chris. So really important to know that NDIS plans are individual. So what that means is a participant, they're unique because it's about what a participant would like to achieve in their future. A list of other supports to help meet these goals, such as the support provided by family, friends, and other government services, like schools, university, training providers, which is really different and unique for each person. And also the funded supports provided by the scheme, if appropriate, and when they meet the reasonable and necessary criteria. So types of funded supports. So most people will access a blend of informal, mainstream, and funded supports. The support the NDIS fund must be reasonable and necessary, and they need to focus on what a participant would like to achieve, foster greater independence, social and economic participation, be evidence-based, and represent value for money. So a participant's needs and circumstances can change, so the NDIS plan will need to adjust to meet that. A participant can contact us if their circumstances change, or they can tell us when we check in. So participant check-in was something that started in August 2020. The NDIS launched this as a way in which, especially under COVID, that we could stay in touch with participants and ensure that their needs were being met and relevant adjustments were made. So this was to allow partners in the NDIA to connect with participants, check on their wellbeing, and make sure the NDIS supports their needs. So the check-in will coincide when completing a scheduled plan review, and will give the participant the option for a plan renewal. So this is no change. So for participants who do not require a change to their plan, as they have stable supports, reasonable utilisation and the current plan is meeting their needs. However, it's important to note that this isn't for children under the age of 7. A light touch plan review, which is a minor change. So for participants who require only minor changes to their plans, they have stable supports, have a minor change in circumstances, and have expected utilisation. And a plan review. So this is for when a participant requires more significant changes to their plan. The plan review is an opportunity for participants to check if their supports are still working and are helping to work towards their achievement of their goals. Depending on the participant's preference, a plan review can be done face-to-face or over the phone. Obviously, during COVID, a lot of these have been across the phone, which is something that has been fed back as not meeting everybody's needs. But as we are coming out of the lockdown and vaccinations are increasing, we are hoping to return much more to face-to-face and face-to-face engagement. But it's important to note that has been raised in other forums that a number of people haven't been able to have face-to-face during this time. Plan reviews are really an opportunity for participants to check if their supports are still working and to help to work towards and achieve their goals. Depending on the participant's preference, a plan review, as we said, can be done face-to-face. We offer participants a future plan up to 3 years for those who feel their needs are unlikely to change and who don't think a plan review is needed in 12 months' time. Automatic plan extensions. So participants whose plans are close to an end date were automatically having their plans extended during COVID. This was to ensure no gaps between their plan, to ensure that they can still access the supports they need. A plan extension is different to a plan renewal in that a plan extension is an automatic extension until a review takes place. So when the review takes place, that new plan will replace that extended plan. Next slide. Thanks, Chris. So funded supports. So the NDIS is responsible for disability-related supports, including ages such as wheelchairs, hearing aids and adjustable beds, prosthetic and artificial limbs, home modifications, personal care and domestic assistance that assist people exiting the health system to live independently. Therapies required as a result of a person's impairment, including physiotherapy, speech therapy or occupational therapy, but not treatments. Disability-related health supports. So the NDIS supports for participants Rule 2013, Schedule 1.74 and 75 should be considered in relation to disability-related health supports. So NDIS participants will be able to receive funding for their disability-related health supports they need as a direct result of their disability and as part of their daily life through their NDIS plan. NDIS supports should be related to the participant's ongoing functional impairment and enable the participant to undertake activities of daily living. This may include maintenance support delivered or supervised by clinically trained or qualified health practitioners, where these are directly related to a functional impairment and integrally linked to the care and support a person requires to live in the community and participate in education and employment. A participant's reasonable and necessary supports also take into account any informal supports already available, such as informal arrangements that are part of family life or natural connections with friends and community and services. It's important to know that these reasonable and necessary supports are related to the age of the participant. So what that means is that somebody that would be 28 years of age, let's say, for example, the expectation around what would be reasonable and necessary for a family member to provide them with support with, this is put into consideration when we look at those reasonable and necessary supports. When we are making an assessment of reasonable and necessary supports, the supports will help participants to pursue their goals, objectives and aspirations, increase their independence, increase community and workplace participation, and develop the capacity to actively take part in the community. So very much around building the skills and the ability and maintenance of that participant to be able to live the life that they would like, with a big focus on community and workplace participation. Next slide, thanks, Chris. So the NDIS is not designed to fund supports most appropriately funded or provided by the health system. Assessments, diagnosis and treatments of health conditions, along with medications and hospital care, remain the responsibility of the health system. As a general guide, the following health-related services and supports are not provided or funded through the NDIS. The diagnosis and clinical treatment of health conditions, including ongoing or chronic health conditions or other activities that aim to improve the health status of Australians. These include treatments, services or supports delivered by a doctor or medical specialist, including diagnosis and assessment of a health condition. The support relates to newborn follow-up provided in the health system, including maternal and child health services. Medically prescribed care, treatment or surgery for an acute illness or injury, including post-acute care, convalescence care and rehabilitation. Subacute care, including palliative, end-of-life and geriatric care. Nursing, allied health services, including acute and post-acute services for treating health conditions. Items and services covered by the Medicare Benefits Schedule or the Pharmaceutical Benefits Scheme, nor Medicare gap fees. MBS, Medical Benefits Schedule. Programs most appropriately fund some supports provided by allied health professionals. If the maximum amount of MBS services under an MBS program have been reached and ongoing support is required, participants should discuss this with their planner. Dental care, preventative health and or universal entitlements, or where individuals and families have a role in funding medical and clinical services. Also, the NDIS will not be responsible for funding time-limited, goal-orientated services and therapies, as we mentioned earlier. I think it's important here to also mention YIPRAC, which is Young People in Residential Aged Care. So typically disability-related health supports will be provided by residential aged care facilities in aged care setting for YIPRAC participants. However, if the participant identifies a health support need that is not being met by the residential aged care facility, this should be discussed with the planner. So definitions from the Department of Health. There are some, so concurrent supports. So some NDIS supports may continue to be provided to participants at the same time as they are accessing the mainstream health system. So for example, during an NDIS participant's admission to hospital, there are limited NDIS funded supports that the participant may continue to receive, including assistive technology, support coordination, and specific communication supports where these are provided for in the participant's plan. Acute services are often short in length or stay and generally provided by public and private health hospitals. Acute conditions are those that come on sharply and are often brief, intense and severe. Post-acute services provide follow-up or care after a person's hospital stay, often by allied health services, and can include admitted or community-based rehabilitation. And palliative care. So palliative care is treatment, care and support for people living with life-limiting illnesses. Where an NDIS participant has a palliative care plan in place and is not hospitalised, the NDIS will fund supports required as a direct result of the disability where the supports assists the participant to undertake activities of daily living. These supports may be provided at the same time as palliative care supports. However, the NDIS is not responsible for palliative care. Palliative care is provided by the health system. Next slide, thanks, Chris. So the state territory government is responsible for supporting participants who may require treatment for acute health episodes and require treatment in hospital and clinical care in the community settings, such as hospital and the home. These supports will be funded by the relevant state or territory healthcare system or private health system. The justice system will fund supports for people in custody, in correctional facilities, for example, prison remand centre or youth detention centre, on remand, awaiting or following sentencing. In these circumstances, a participant's day-to-day care and support needs, including personal care and more appropriately funded by the justice system. This means that if the participant has an acute episode where the significant change in their epilepsy needs will require management or treatment in a hospital or other clinical settings, these supports will be funded by the relevant state or territory healthcare system or private health system. NDIS will not fund epilepsy supports during this acute episode while the participant is in a hospital or clinical setting. If a participant receives disability-related health supports for epilepsy in their plan, the NDIS will recommence funding when the support ceases to be acute but continues to be regular. So this is putting it through that lens of understanding the responsibilities of the other systems. Next slide. Thanks, Chris. So kind of touched upon this briefly before. So understanding where there are those gaps in those systems. So this is part of the Disability Reform Council. One of the things that was adjusted because there were gaps were disability-related health supports. So in June 2019, the Council of Australian Governments, otherwise known as the COAG, and the Disability Reform Council held its first meeting. So from the 1st of October 2019, members of the DRC, as well as the Commonwealth and state territory governments, endorsed 5 major reforms to improve the delivery of the NDIS, with the main announcement being an agreement between Commonwealth and state and territory governments that the NDIS will fund a range of disability-related health supports where they are part of the participant's daily life and result directly from the participant's disability. To access disability-related health supports, a person must meet the NDIS eligibility requirements and be an NDIS participant. And the need for disability-related health supports must directly relate to an NDIS participant's functional impairment where the support need is ongoing and best provided by the NDIS. The health system will continue to be responsible for all acute, post-acute, e.g. hospital and in-home, as we've really reinforced with this presentation, and chronic health conditions not related to a participant's disability, diagnosis and palliative and time-limited ongoing conditions. So really, you see that NDIS is really funding those disability-related supports. However, there are those options where we will fund those health supports where it's related to the functionality. Really important to remember that functionality and participants' ability to how their disability affects their ability to do that. So really important. You can see that it continues to come up through the presentation. NDIS participants can have disability-related health supports in their plan if they are reasonable and necessary, remembering that they are not funded by another assistant, they're best funded by the NDIS, and they are related to a participant's disability. Disability-related health supports can be delivered by a suitability competent worker, which may include nurses and or allied health practitioners. Once a plan is in place, a participant can purchase these supports like any other item in their NDIS plan. So next slide, thanks, Chris. So we've got a bit of a table here. Dysphagia is up the top, but we understand that this is really focused on the epilepsy side of things. But so we'll talk about epilepsy first. So any disability-related health supports that meet the reasonable and necessary criteria can be included in a participant's plan. Typical types of supports can be grouped into 8 support type categories, but these are not an exhaustive list. So remembering that this should be really individualized and presenting the information in relation to the participant and their needs may lead to those supports being included. So this is not an exhaustive list, it's just an overview. Supports that the NDIS stated to fund from October 2019 included epilepsy supports for participants who need daily help managing the way that epilepsy affects their brain and nerves work. Examples are training to implement the participant's epilepsy management plan and emergency medication management plan. That's the main one we'll focus on. I'll give you just a brief overview of dysphagia supports. So development and implementation of mealtime management plans, swallowing therapy in terms of respiratory, implementation of clinical care and daily maintenance and care, provision of tracheostomy, equipment and consumables, CPAP machines and consumables in regards to nutrition, implementation of a nutritional meal plan, PEG maintenance and care, home home enteral nutrition, so purchase of formula and nutritional supplements, diabetic management support, so development and training to implement a diabetic management plan, catheter maintenance and care, continence and consumables for continence support, wound and pressure care supports, wound care and pressure care consumables, training and the cost of lymphedema machines, and podiatry and foot care, so assessments and the development of a podiatry care plan. Next slide. Thank you, Chris. So thinking about disability supports, so disability-related health supports are expected to assist participants who need daily help managing the way that epilepsy affects them. So generally, the NDIS will fund disability-related supports where a participant is unable to manage their condition due to their disability, or a child's epilepsy-related needs are above what a parent is able to provide for and are specifically related to their disability support needs. So funds that may be funded in supports that may be funded include assistance to link to mainstream supports to enable the participant to complete an EMP or an epilepsy management plan or emergency medication management plan if no informal supports are in place for this purpose. For children under the age of 7, this is unlikely to be funded because there's an expectation that as the parent, this is a parental responsibility, which is unlikely, but it doesn't mean it won't. So I think it's important to know that each case, as we've said, is really should be looked at as an individual basis. So this is guidance, and there are times where people may have it funded. Epilepsy seizure monitoring by a support worker or a nurse in some circumstances. Training a support worker to implement a participant's EMP, EMMP, and ketogenic diet plan. Once again, difficult for children under 7. A support worker to implement a ketogenic diet plan. Assistive technology for seizure monitoring. For example, monitor alarm systems, seizure maps for beds, oximeters. Sorry, mouth is getting dry. You would be aware of what an epilepsy management plan is, so I don't feel I need to go into detail around that. And I'm sure you would be aware of what emergency medication management plan is. Next slide. Thank you, Chris. So important to note here that we talked about the access before, but access is getting onto the scheme. This is planning. So it's just important just to remind around the planning and things that would be really beneficial to be presenting. So once an individual gets eligibility to the NDIS, the next step is to have a meeting with their NDIA planner or LAC with support from a family or carer if that's their preference. The planner or LAC will learn more about the person to determine the current support needs from their families and carers. So the planner will consider a range of issues such as, is the disability-related health support directly related to the participant's ongoing functional impairment and required on an ongoing regular basis? Should the support be provided by the health system? What disability-related health support is the participant currently receiving? What are the specific details of the disability-related health supports that the participant requires? Does the participant have any disability-related epilepsy supports they need but are not currently able to access? For those who are currently accessing epilepsy supports, examples of questions the planner may ask. So it's important to note that these are questions that the planner may ask. They may ask them, but it's probably good to be prepared with these information to present to the planner also, just in case the planner doesn't ask them. So being prepared with that information to help get included the supports that you or your loved one requires. So what specific epilepsy supports are provided? How often are those support provided? For example, daily or weekly? Who provides these supports, such as a support worker via registered nurse, delegation of care, RN, family member and the service provider, giving the names of these, Do they currently use any assistive technology or consumables? Do they have any capacity building goals in relation to their epilepsy management? Or is there any support that will assist them to be more independent in relation to their epilepsy management and support needs? Copies of any current reports, treatment or care plans, for example, medical reports or assessments from a treating specialist, such as a paediatric neurologist experienced in epilepsy management, a GP, occupational therapist, physiotherapist, nurse. These should be provided to the planner to help them learn more about the participant's need for disability-related health supports. Examples may include, as we said before, an EMP or ENMP or a functional capacity assessment. So it's important to note that this information is really important to give to the planner to help them make those reasonable and necessary decisions. So just remembering that these are the type of things to help prepare for that meeting. And although we do know that these are questions that should be asked by the planner, this may not always be the case. So it's important that you're aware to be able to present that to them. Next slide. Thanks, Chris. So for disability-related health supports, participants must be requested to provide, may be requested to provide information from an appropriate healthcare practitioner about the proposed support. This may include type and availability of support recommended, frequency and duration of the support, care and maintenance of the support, whether the delivery of the support can be delegated, for example, by a nurse to a disability support worker, the relationship of the support to the participant's functional impairment, outcomes that will be achieved through the delivery of the support, and most appropriate setting for the delivery of this support. The NDIA may require evidence to be current. Currency is dependent on the type of support, relevant risk, and changing needs of the participant. In relation to the epilepsy seizure monitoring, the plan developer will refer to the following evidence if it's available. Assessments from a treating medical practitioner. This can include diagnosis, confirmation of the requirement for epilepsy monitoring, and other supports to manage the risk of seizures. Functional capacity assessment that provides a description of the participant's overall need for support and activities of daily living. This should include confirmation of an overnight support plan, including whether the participant requires active or passive overnight support, perhaps in conjunction with the use of assistive technologies to meet the participant's support needs. An epilepsy management plan that sets out the type of seizures, seizure triggers, risk mitigation strategies, support required during a seizure, any emergency procedures that should be followed, post seizure triggers, support needed for overnight support. Describes the medication, so the epilepsy medication management plan, describes the administration, dose and instructions for the administration, the dose and the emergency procedures. This needs to be completed by the doctor who provides the medical management or prescribes the medication. The functional impact of the seizure will determine the related supports the participant needs. Once again, that's how that reasonable and necessary decision is made around where the support best sits to be funded, and helps to articulate that picture of the participant and their support needs and the structures that are in place and what is required at times to maintain that. So next slide. Thanks, Chris. So just important to have a look at the support budget. So remembering there's core supports, capacity building supports, and capital supports. So as we know, participants receive reasonable and necessary funding and the relevant budget depending on their support needs and their plans. To support participants have choice and control over their plans, there is flexibility to ensure they can choose how to spend the funds to live life in the way in which they choose. So core supports help a participant with everyday activities, their current disability-related needs, and to work towards their goals. For example, this can include support workers to assist with daily living activities such as cooking, cleaning, and personal hygiene, where the person's disability prevents them from doing this on their own. May also include transport, support for household tasks, meal preparation, support for community access, and consumable items such as continence products or wound care. Examples of disability-related health core supports are where reasonable and necessary criteria are met, low-cost assistive technologies, which is up to $1,500, such as a seizure monitor or alarm system, seizure mats for beds and oximeters to measure a person's oxygen saturation. Personal care hours for daily activities. These can include hours for a support worker to attend training to implement epilepsy management plans and emergency medication management plans, attend training to implement a ketogenic diet plan. This can be reviewed when there is a change to the diet plan, implement a ketogenic diet plan, shop for and cook. The frequency of support will need to be decided depending on the participant's capacity. Support may be required daily or weekly at the start of the plan and decrease in frequency over time as the participant begins to become more understanding about that and develops their skills. Monitor the seizures where the level and risk of the seizures are high due to the severity of the participant's epilepsy. The hours funded will depend on the participant's other disability support needs. Additional time may be required for the support worker to travel to provide daily activities as per the NDIS pricing and arrangement and price limits guide. Within the capacity building supports budgets, this is to build a participant's independence and skills to reach their long-term goals. Funding can only be used to purchase approved individual supports that fall within the capacity building category. For example, disability-related therapies such as nursing supports, occupational therapy, speech therapy, physio, peer mentoring, behaviour management, and support coordination and plan management. Examples of disability-related health capacity supports may include in capacity building. Capacity building supports may enable the participant to better engage in strategies to manage their condition and reduce the risk of seizures or otherwise build their skills for everyday life and a capacity for social and economic independence. For example, to implement a sleep routine, undertake exercise, or implement other lifestyle or strategies as recommended by their treating practitioners. The plan developer will need to consider whether the need arises due to the functional impairment of the participant's disability and whether the need can be met by the participant's informal networks, the community, and or mainstream supports. Nursing hours for epilepsy seizure monitoring. So composite nursing hours where the complex health and disability care needs of the participant exceed the skill set of a trained support worker, as evidenced by a functional capacity assessment, EMP and or EMMP, indicating a registered nurse is required to meet support needs, or whether support could be provided by a support worker under delegated care model. The participant's treating medical practitioner can also be asked to provide supporting information in regards to the support required. Training and assessments of support workers under the RN delegation of care. So funding for a registered nurse to train support workers to deliver the delegated support based on the participant's care plan. Any additional time required for provider travel to provide assistance for daily activities. And within capital support budget, so this is really focusing on higher cost pieces of AT and home or vehicle modifications and funding for one-off purchases. So examples of where disability-related health capital supports may be provided: purchase or lease of an assistive technology over $1,500 per item. This includes specialist and complex assistive technology items that may carry significant risk or injury, hospitalization or death if not assessed and set up correctly. Repairs and maintenance are covered for any assistive technology that is funded by the NDIS. Epilepsy monitoring to assist the participant to be safely cared for, or that reduces and negates the need for a support worker to provide face-to-face monitoring. Assistive technology may include, as we said, seizure monitor alarm system, seizure mats for beds, and oximeters to measure a person's oxygen saturation. Epilepsy seizure assist dogs. The NDIS will not fund an epilepsy seizure assist dog. It is neither an NDIS responsibility nor a health system responsibility. Currently, there is insufficient evidence in published and referenced literature to support the use of epilepsy seizure assist dogs as an effective disability support. Next slide, thanks, Chris. And this is just 5 types of disability-related health supports that have been identified in the support catalogue. So provision of disability-related health supports by the NDIS support worker. These supports should be claimed using the standard daily personal activities and high intensive daily personal activity support item. Assessments, planning and provision of disability-related health supports by therapists. So these would be claimed using the standard ECI and therapy support lines. Assessment, planning and provision of disability-related health supports by a nurse. As that would suggest, these should be used to be claimed by nursing supports. Consumables related to disability-related health supports. So this is for consumables related to disability-related health supports, and assistive technology related to disability health supports. Next slide, thanks, Chris. So now we've got a couple of case studies just to give some examples of where that funding can be put into a plan. So Mary is a 3-year-old who has cerebral palsy and complex epilepsy syndrome. In a planning meeting, Mary's parents explained that Mary co-sleeps with them in the bed so that they can be there to monitor any seizures overnight, as her seizures have previously resulted in Mary's breathing stopping or in her moving into unsafe positions. Mary's mum explains that Mary's neurologist, has prescribed a ketogenic diet plan to help control her seizures. Mary has an EMP in place that describes how to recognise when seizures are occurring and to give clear directions about the appropriate support and first aid to be provided when Mary has a seizure. Mary's mum, with help from a community organisation, wrote the EMP. So an outcome of this is that generally the NDIS will fund epilepsy-related supports where a participant is unable to manage their condition due to their disability, or a child's epilepsy-related needs are above what a parent is able to provide for, and it's specifically related to their disability support needs. In this example, Mary's NDIS plan may include funding for seizure monitoring by a support worker or nurse. Consider whether seizure monitoring by a support worker is required for Mary overnight, so that she is able to sleep in her own bed. Training Mary's parents to implement a ketogenic diet plan. Assistive technology for seizure monitoring. The following health supports were determined to be not reasonable and necessary. So ketogenic diet, as this is considered a parental responsibility. Development of an epilepsy management plan, as there are a number of community organisations that provide epilepsy management planning. The early childhood partner can link families to community organisations for this support, but acknowledging that this may seem like a very easy way to address it, and understanding that looking for these supports may be more difficult than what we are stating, but it's just trying to articulate that this is why that decision would be made, as it is felt that it better sits under the health setting. Next slide. Thank you, Chris. So Josie or Jose or Jose is a 48-year-old participant with an intellectual disability and epilepsy, currently living at home with his elderly parents. So during the planning conversation, it was reported that Jose has treatment-resistant epilepsy. There are no known seizure triggers, and he could have a seizure at any time. He'll shortly move into SDA, which is otherwise known as Specialist Disability Accommodation, with 24-hour SIL support, so supported independent living supports. The provider has submitted a quote indicating that Jose or Jose requires 24-hour support. All people who support require training in his EMP and his EMMP in order to administer a buccal midazolam when he has a seizure. The SIL provider has stated all staff will require training in how to provide support to a participant with epilepsy, and have submitted a quote for $350 per support worker to attend a training program delivered by an epilepsy support organisation. So the outcome of the planning was that the following health supports were determined to be reasonable and necessary. So one-to-one support for assistant with daily activities and seizure monitoring due to the complex support needs and unpredictable seizure activity. It is also acknowledged he will require constant support to meet his disability support needs. Support worker to implement the EMMP and the EMP. support worker hours to attend training specific to implementation of EMP and EMMP. The NDIS, it was found, was not responsible for funding the epilepsy training program itself. And next one, thanks, Chris. So Michelle was 30 years of age and has primary disability of spinal cord incomplete injury. So additionally, Michelle has a number of complex diagnoses, including epilepsy, multiple seizures in a 24-hour period, profound intellectual disability, severe osteopenia, and pressure sores. Michelle lives at home with her mother and brother, who provide the majority of the care supports. Her mother is her appointed guardian and NDIS nominee. So during the planning conversation, Michelle's mother explains that she spends the majority of her day in a wheelchair, recliner, air pressure care, or in her hospital bed. A 24-hour positioning plan indicates Michelle requires regular repositioning to manage pressure sores. A neurologist report recommends that Michelle requires constant supervision due to the many seizures she experiences throughout the day and night. The neurologist has indicated that Michelle's profound intellectual disability means she cannot ask others for help, which places her at risk. The neurologist also indicates that Michelle takes medication 3 times a day by her PEG tube to manage her epilepsy and requires the administration of medication, midazolam, when seizures occur. Functional capacity assessment completed by an occupational therapist indicates Michelle requires a voice with 2-to-1 support for all transfer, relies upon carers for all activities of daily living, and utilises a tilt-in-space mobile shower commode for personal care. A report from a hospital clinic indicates Michelle relies on home enteral nutrition and is fed by a PEG tube and relies upon a specialist feeding formula to help manage seizures. Michelle currently has a 1-to-1 NDIS funded support to meet her personal care needs and to access the community. Her brother and mother have provided assistance as their second carer for activities such as hoist transfers, but her mother indicated they are struggling due to health issues and employment responsibilities. Michelle doesn't have an EMP or an EMMP as her mother has managed her epilepsy supports. Michelle's mother will continue to act as a guardian NDIS nominee. A request for 2-for-1 support at all times has been made, and funding for a nurse to prepare an EMP and an EMMP. Michelle's NDIS plan, the outcome being that Michelle's NDIS plan provides funding for the following reasonable and necessary health supports: 2-to-1 support 6 hours per day. Michelle has complex disability support needs. It's clear from the functional capacity assessment that Michelle will require 2-to-1 supports to meet her personal care needs as per the NDIS operational guidelines. Personal care, it is reasonable and necessary to include this funded support in Michelle's NDIS plan. These funded supports can include support to prepare and provide Mel's specialised hand. 1-to-1 support, 18 hours per day. Michelle's unstable and unpredictable seizure activity in conjunction with her complex disability support needs means she will require constant monitoring. It would be reasonable to fund 24-hour support for Michelle at 1-to-1 basis. This could include active overnight support to monitor and respond to seizures. A nurse to prepare an EMP or EMMP would not be considered reasonable and necessary. These can be prepared by Michelle's mother as a guardian and endorsed by the treating health medical practitioner should Michelle's mother require support to develop these plans. And that's just some examples of some further information that's available, but understanding that you guys have been engaging with the NDIS, I think the planning booklet is probably useful to think about that review and maybe to help gather that information that may be required in that review planning meeting. And then finally, on our final slide there, we've got our contact details, which communityengagement.westcentral@ndis.gov.au. Now, the reason why we put that there is obviously outside of this session, you may go away, you may have more questions, and maybe more things specifically in related to your experience that you're wanting some clarity around.
we are more than happy to have an email sent to us. And as Chris said, we will liaise with Chris outside of this meeting, outside of this session, if there are any further questions that come to the group, so that we can help to ensure that we get the correct answers and messaging to you.